Good evening, everyone, and welcome to the 22nd monthly case webinar. My name is Danish, and I'm a product specialist at Collective Minds. Thank you for everyone who's joining. There's a few of you still coming in now. Um, I'll be joined by no other than Dr. Imran Lasker, consultant radiologist, who'll be looking through some plain film, CT, and a few MRI cases this evening as well. We've also had some donated cases by you. That Imran will be having a look at. If you also want to donate any cases in the future, just at Doc Lasker in the reply section of any cases in the global community, or when you're uploading any cases to the global community yourself, you just include it in the case details. So that's at DOCLASKER Doc Lasker, and he'll be able to take a look at your cases and review them in the upcoming webinars. I'm also going to post the collection for tonight's cases in the chat box now, so you can follow along. If you have any issues getting onto the platform, do let me know in the chat box, or you can email us at support@cmrad.com, and someone will be in touch to sort anything out regarding to access. Yeah, there's the collection. And finally, I'll be sending you a quick survey at the end of this webinar, just to get some feedback on the webinar tonight, and also for you to get your CPD certificate. You should complete that survey, and then we will be able to send you out your CPD certificate. So with no further ado, I'll hand you over to Dr. Lasker.
So hi everyone, hope everyone's well. Thank you so much for coming. I think we're coming up to Easter holidays and stuff, so people are generally quite busy around now, I think. And I myself and Danish are fasting as well. So I'm going to say in the middle of this, I am going to break fast, and I will still go through cases, but I'm going to do something a bit different. I'm going to play a video of me going through a case. So it gives me a little bit of time to break fast, quickly pray, and then come back. I hope that's okay. But anyway, I'll give you plenty of warning before I do that. So what we're going to do now is just open the cases. So hopefully we have got the cases ready for you guys. I think you guys should have the link. I'm going to just open the chat over here so I can see what's going on, and the Q&A as well, so I can keep track of what's happening. Right. So I hope everyone is doing okay. Everyone's logged in and everyone can actually access the cases. If you just get a few thumbs up, that would be cool, so I just know where we are. Fine. So for those that don't know, we're just going to go through some interesting cases. Hopefully, it's a bit of a medical entertainment style situation. Obviously, just throw in your suggestions, any jokes, anything you want, put it into the chat. I do normally pick it up and I try and answer to the best of my ability. Not saying I'm an expert in everything, so it is just important that we all kind of learn from each other as well. So let's go to the first case over here and just have a look. And I want to go to the X-ray first to kind of make it a bit easier. Just click on that download button, that little kind of cloud, and then you should be able to look at the case at the same time as me. So let's have a look and see what we think is going on here. So we are looking at an adult, and also if you think you know what's happening, just throw it in there. Some of you may cheat and go ahead to that CT scan. So let's have a look. We can see that this is a chest X-ray of an adult patient, and you want to have a look at the lungs and make sure they're nicely inflated, and they do look like they're nicely inflated. And one of the things I like to do is have a look at the lung apices and just make sure that there's no evidence of any pneumothorax, because often you find that pneumothoraces are missed there, and you've just got to really, really look and try and see if you can find any sort of lung marking that doesn't go all the way across. So generally speaking, you have lung markings that go all the way across to the very, very edges. So this looks like it actually goes okay. It doesn't look like there's any pneumothorax here at all. And then this is slightly rotated. I don't know if you can see that, but this is the medial edge of the clavicle there, and that's probably the medial edge of the clavicle there. And this spinous process is really far towards that direction. So this patient feels they're pretty much rotated, aren't they? So you're not really going to get an en face appearance of the mediastinum. But you can kind of infer there's probably not much in the way of any lymphadenopathy. That's going to be the aortic knuckle over there, and you can see the hilar just sitting over here. This hilar looks okay, but when you come up to this kind of area over here, can you see it kind of looks a little bit indistinct? It looks a bit abnormal. And so you've got to think to yourself, okay, what's going on there? Like, why is that abnormal? What kind of anatomy is in that particular area? So your lymph nodes are going to be around this area, really. So it's not going to be a lymphadenopathy. It doesn't look very globular in appearance at all. Someone's come out with a very good suggestion, exactly. So there is what looks like an opacity located within this region. If you compare that area of your lung there compared to that area of lung over there, that looks very much like it's much denser. Now, when you look at that right heart border, generally speaking, when you look at the next X-ray or any other chest X-ray, you should be able to see that right heart border really easily, very, very distinctly. But when you can't, it must mean that it's a very specific part of the anatomy. It's going to be the right middle lobe. If you could see the right middle lobe, if you could see that right heart border, then you're probably looking at a right lower lobe opacity or right lower lobe abnormality. So this is definitely some sort of density located within the right middle lobe. So the other thing I'd say is that this heavy diaphragm looks slightly elevated, doesn't it, compared to the other side? Yes, it could be the rotation, it could be the angle that we've got this patient in. But actually, it does look a little bit elevated. So you'd be wondering whether is this really an opacity or whether this is actually an underlying collapse. So now as you would, you'd end up getting a CT scan for this patient. Let's have a look at the CT scan, and we'll go from the very, very top. So I always do one scroll through from the very, very top before I really say anything or think anything, even in NDT, and particularly in the exams. I just did one scroll through from the very, very top before saying anything, and then come all the way back up again. And then I'd go to the lung windows, and it's really good with collector mind. You can just press one, two, three, just like you would with your normal packs. And yeah, now you can see the lung windows, and I think that was number 4. So if you want to do it too, you can press number 4 and scroll through, scroll through, scroll through, and then we are coming up to where the right middle lobe was. So the right middle lobe here, you can see that there's opacity that is located there. Let's try and draw out some of the anatomy a bit. So that's the left upper lobe. You've got this oblique fissure going across, and then you don't really seem to have any other fissure. So maybe worth just doing a coronal view and trying to see if we've got any other fissure. Like you should really have an oblique fissure, shouldn't you? So let's see, coming across, not really. So yeah, what's happened is that you've got what looks like a complete collapse of the right middle lobe. And so someone has said, and correctly so, let's have a look. What's going on here? So yeah, so we've got some lymph nodes here, don't we? So this whole area here, you can see some hyperdensities located within this region. And actually a few hyperdensities are also located within this region over here. And so if you go to the bone windows, can you see, if you're not sure, these are calcifications, that's calcium, that's calcification, that's calcification over there as well. So you've got multiple calcified lymph nodes within the mediastinum. Let's see if we've got any other calcified lymph nodes anywhere else. No other calcified lymph nodes anywhere else. Axilla, they look all clear as well, and the rest of the mediastinum looks okay as well. So can't see any enlarged lymph nodes anywhere else from what I can see. Or maybe that one's slightly big as well, but no calcifications within there. Now, there is a calcified granuloma, what looks like it's just sitting within this region over here, but the rest of the lungs look okay. Let's look at the upper abdomen just to make sure there's nothing else going on. So there is quite a wide differential for calcified lymph nodes. Sarcoid is one of them, and sarcoid is something that I would consider. Oh, someone's put a few in, but yeah, exactly right. So histoplasmosis, tuberculosis, silicosis. There's loads and loads of differentials for calcified lymph nodes. And obviously, going with common things are common, you probably want to say most likely to be in keeping with sarcoid, but you'd want to also look at the lungs and have a look at what the lungs look like and see if you can find any sort of periphyseal nodularity. So you look at the fissures like this and see that any tiny nodules scattered along, any like net-like appearance to lungs, any nodularity of the lungs, anything like that. And actually, I remember the other day I was messing around with this and I found that you can actually do MIPS on here as well, which I thought was pretty impressive. So if you do this, and then if you go here and then drag it along like this, which is pretty impressive for like an online platform like this, you just got complete like full whack DICOM viewer material here. So we can scroll through and see if we can see any particular nodularity. And I can't say I'm convinced there's anything more nodule than what we've seen already. Actually, you know what? I've done a really big MIP on that for some reason. So normally do about 10 and then scroll through and see if you can find anything. But I haven't seen any nodules anywhere. So this looks like there's multiple calcified lymph nodes within the mediastinum, and this has caused obstruction of the right middle lobe. Differentials for this exactly like what you've said: histoplasmosis, tuberculosis, sarcoidosis, silicosis. Those are all possibilities as to why this patient's got this problem. The main reason I brought this in really is because of that right middle lobe anatomy. It's quite important to be able to identify when something's right middle lobe compared to anything else. Right. Let's go to case number 2. Let's concentrate on the X-ray to begin with and see what we think. So we've got an AP view of this X-ray, and we'll go to like this and actually just download it as well. Download this one. I think you've got to download them separately because they're different modalities. So at first, it doesn't look too bad, right? It looks like joint spaces are nicely maintained. Anterior compartment looks okay. Hof's fat pad looks okay. No, not much in the way of an effusion or any lipohumoral arthrosis anywhere on the suprapatellar region, which is over. Sorry. Oh yeah. So that was the last one. Sorry, I should have done that. So let's ignore that. Ignore that vote. I'll tell you for the next one. Okay, so let's have a look at the bones now and just see what it looks like. So actually, it doesn't look like there's any sort of avulsion of any of the tibial spines. And look at the medial tibial plateau. Someone said something can see there. Let's have a look. Let's zoom in. Let's zoom in. So you think it may be a tibial plateau fracture. So you've got to kind of go along like this, go along like this. And I can't really say I can see one. If you're talking about this area here, that actually looks pretty good. You know, that looks like it's okay. I mean, you can have a little bit of a bump because of the old growth plate they used to have there. And you can see that kind of old growth plate they used to have there sitting along there. But it doesn't look like there's a fracture. The lateral tibial plateau looks okay. Sometimes you get fibular head fracture, but that looks okay as well. You also want to look at this area over here. Just make sure there's no avulsion of any fragments anywhere over here, but it doesn't look like there's a gone fracture either on that side. But actually, if you come across to this side, can you see that this doesn't look quite right? The little flake of bone that's sitting across there, it doesn't look quite normal. Now, when you kind of zoom out a bit and have a look at that subcutaneous planes over there, and look at the subcutaneous tissues over here, it looks a bit more like strandy, right? And it's the same as fat stranding and the rest of the body. It looks slightly more stranded. This whole area looks a bit more inflamed. You know, when you look at your medial knee as well, like if you to touch, most of us who touch the medial knee shouldn't really have much in the way of soft tissue. Should really be quite, you know, skin to bone almost. But this looks like it's quite edematous there as well. So you'd be concerned there's some sort of avulsion fracture. So anatomy wise, what do you really have there? You only really have one thing. That's going to be the MCL, which are going to be attached in that region. So now what we'll do, I don't really do think I do very much in the way of MRI on these talks. Maybe I should start doing that. Well, anyway, this is the fluid sensitive sequences. This is what fat looks like on this particular sequence. And if it looks kind of darkened, therefore the fat's been saturated, pulled down. And now anything that's fluid is going to be bright and anything that's fat is going to be dark. And obviously you've got very, very dark stuff, which is going to be the cortex, which doesn't have any fluid or anything like that. And tendons are very, very dark as well. They're very, very dark. And menisci are generally quite dark unless they get injured or have some degenerative changes that happen over time. Now, when you come up to the medial aspect over here, which is what we're looking at on the X-ray, so if we actually get them side by side, put it like this, and let's zoom in a bit, like so, and then pan across. So that area corresponds to about this area. And you can see actually the MCL looks like it's okay. It doesn't look like it's torn, but coming up sort of more anteriorly, it does look like it's slightly discontinuous and there's a lot of edema within this region. So you've got deep fibers and superficial fibers of the MCL, and sometimes you get a tear of like a disruption of the deep fibers. Sometimes you get a tear of the superficial fibers. This looks like to be the anterior superficial fibers more than anything else has got this sort of edema, and coupled with what looks like an avulsion injury, it seems like they probably avulsed the medial collateral ligament from the actual femoral attachment. I mean, what could cause that? You know, most likely it's going to be something known as a clip injury. And actually, you would expect a lot more of a bone contusion from from a clip injury. A clip injury, I don't know why the emojis keep coming up, but it's generally when you're, let's say, playing rugby and it's some or American football or whatever, playing football, and someone tackles you from this side. The impact's here, and you end up having this sort of kind of bending of the knee this way. So generally speaking, you would have a bone contusion here and a bone contusion here, but this area would be kind of quite pulled apart, and then therefore you can have these injuries. The other thing that can cause sort of MCL injuries is going to be a pivot shift injury where you get a twisting and valgus, or like a twisting and opening of the joint again. And that can cause stretching of the MCL, and that can also cause avulsions. Now, generally speaking, pivot shift injuries are more likely to be in keeping with an MCL tear, which this isn't. Actually, I probably shouldn't say that just in case. Oh, we don't have any sagittal views. Normally, I look at the sagittal views, but that's the ACL over there. You follow that, follow that, follow that, follow that, follow that. And you can see it does actually attach to the tibia. And you can see the PCL also attaching to the posterior aspect there. So it's not going to be like a PCL injury or an ACL injury or anything like that. This is looks like a very kind of focused injury of the MCL. Now, when you're thinking about these things, there's a lot of edema, but there's a flake of bone, and you'd expect quite a lot more edema. So maybe a situation where they've had this initial problem and then it's taken a long time to get the MRI, or they've sat around for a long time trying to hope it gets better. It's not got better, and then they get the MRI. So sometimes you have these kind of injuries, but not much in the way of soft tissue edema. And some of the secondary bone contusions may have theoretically got better by now. Okay, so let's go on to the next case. And I can't remember what this case is. I'll have to work this out with you guys. Um, Okay, so this is a foot. Looks like it's of an adult patient. And one of the first things I do with these patients is just to make sure I've had a look at the metatarsals, right? And make sure you've had a good look at the metatarsals. And it does look a little bit hazy there, but not cloudy. You want to have like a proper like, mist appearance for it, for you to say that this is going to be an underlying stress fracture. But this all looks okay. It looks kind of very uniform. It doesn't look like there's anything going on there. The next thing you want to do is have a look at the metatarsal heads, make sure they're okay. There's no evidence of any Freeburg's infraction or anything like that. And actually, that looks okay as well. We can't see any Freeburg's infraction. And then you want to see the alignment of the metatarsals. So for those that don't know, there is a ligament that goes across like this, attaches to the base of the second metatarsal, and that would be a Lisfranc ligament. And if you get an injury, sometimes all the metatarsal just slip across, and all you'll see is that malalignment between here and here. That's all you'll see. But this looks like it's okay, actually. It doesn't look like there's any malalignment there. Sometimes you get some osteoarthritis over in the metatarsal head. Haven't seen anything there. And then this is when you really got to do the hard work and zoom in on absolutely everything. I always warn people, whenever you see any sort of line around here, make sure you draw all the way around to make sure it's not just a nail bed, because some people have called fractures when there aren't any, no fracture there. Everything looks okay so far. Everything looks okay. And actually, you may have noticed that looks like something's been bandaged, doesn't it? Like there's some sort of hyperdense material like this going across like so. Actually, maybe it's going across more. And now when you look at this, there's some bandage, but there must be a reason why they've done this bandage. And it looks like they've actually fractured a fair bit of their proximal phalanges. So you can see there's a fracture going across here on that third phalanx. There's some fragment over there. It's probably like a bit of a comminuted fracture. You've got an oblique fracture that going across there. And actually you've got quite a significant displaced fracture on that fifth. So often, I don't know if you guys get this, but with us anyway, you often get someone who's broken their wrist or broken their hand and will say punched a wall. And I've noticed that sometimes you get something like say kicked a wall. And actually, what they're trying to do is hide the fact they probably tried to kick someone. I'm not saying that's what happened. I'm not saying that's the same for everyone, but I've noticed that that is a bit of a pattern. But it seems like if they did try and kick anything, a bit of a weird way to kick, because normally the majority of the impact would be around here, not here. So maybe they've actually dropped something rather than actually kicked something. But yeah, quite extensive fractures there. Also, you want to just make sure of the base of the fifth. And the base of the fifth looks okay, doesn't it? It doesn't look like there's any fracture there. And I've noticed a few fractures in the navicular, and they literally be like a straight line like this. So just be careful in the naviculars, and then the lateral malleolus, medial malleolus. If you can see them, you can't ignore them. You just have to look and make sure there's no like ankle fracture or anything like that. And then last but not least, it can be like a talar dome osteochondral defect. Just make sure you've had a look. But this one looks to me as though there's no other fractures apart from the third, fourth, and fifth. And before I say that, I just want to make sure there's no fracture on the second. That looks very nicely lined. And then you may be seeing that line there, but actually, if you follow that around, that looks like the line of the actual soft tissue, of the big toe. So yeah, we're going to have to go with 3, 4, and 5. 3, 4, and 5 fractures, and particularly displaced fracture, probably comminuted fracture on that on the second one as well. Right, so let's have a look at this hand. So don't worry, guys. I have got my water at the ready and my dates at the ready as well for when I need to break fast. I am starving today. Well, I don't know if I hope if anyone is fasting, I hope it's going well for you guys. Right, so let's have a look. So this looks like they've kind of concentrated on the wrist, and let's have a look at this one first, and let's zoom in and just see what's going on here. So sometimes you get on the styloid fractures, they can be pretty obvious. That looks okay. Looking at the scaphoidal junction is probably not the best way to look at the scaphoidal junction. You don't have a dedicated view. Let's have a draw around the radius. So sometimes you get a kind of radial fracture there, but you'll often get this bump. So please don't get put off by this little bump sitting here. I think it's still a remnant of previous growth plates and that kind of thing. So around there, so you zoom in, so scaphoid, so that's going to be the scaphoid, and that actually looks okay. It doesn't look like there's a fracture there. You got your triquetrum over here, and you've got your hamate over here. Everything looks okay, and this all looks quite nicely aligned. So let's zoom in, and have a closer look. I might need to window a bit, and obviously, you write down what you think what you think as well. But there does seem like there is a kind of faint radiolucency, maybe. Can you see that kind of going that way? But it's not as well. So normally when you look at fractures, you want to get it to see, you want to see it like as a complete like fracture, like a complete radiolucent line. But it feels like there's a bit of cortication as you come up to it, but you can't really explain as to why someone has got a line like that there. So now we need to sort of zoom in a bit more, trying to concentrate on that particular area. And we can see that that scaphoid is sitting there, and that looks okay. But now when you come back to that radius, that radial area that we're talking about, come like this. And then actually, yeah, that radiolucent line looks far more obvious over there. So let's see where we could be. So if the thumb is over here, then you're probably looking at the dorsal aspect. So it feels like a fracture, sorry, a fracture of the dorsal aspect of the distal radius. Yeah, so that must be what this is. This is a fracture of the dorsal aspect of the radius with articular self-involvement, and the rest of the radius is okay. And you can't see any other fractures anywhere else. And you can't say this is like a composite shadow or anything, because if you draw the lunate like this, that doesn't go and continue with this line. If you draw the radius like this, it doesn't continue with this line. Draw the ulna like this, it doesn't continue with this line. This is a specific kind of sitting alone by itself fracture line that's sitting there. So a this is clearly a fracture of the distal radius. Right, so let's go on. So there's no question so far. So let's go on to this next case. Okay, so let's go for the X-ray first. And again, click on the download button. Download, oops, what happened there? Download button, and let's make it a 1:2 and have a look. So first we've got nice views here. So we've got the sort of axial view and we've got the AP view. We don't have a Y view, but from the looks of things, that head of humerus does look like it's articulating quite nicely with the glenoid. So that looks like it's articulating great. Doesn't look like there's any problems there. Acromioclavicular joint, no fracture there and no abnormalities there either. And sternoclavicular joint looks okay as well. And the acromion looks okay there as well. Let's have a look here and make sure everything's articulating nicely. Yeah, it looks like that glenoid and this kind of overlaps quite nicely. The humeral head overlaps. So why don't you guys have a look at this? And I've just put this I put this little poll up for you guys to try and have a look and see what you think. So do we think it's some anterior dislocation? It looks like it aligns quite nicely, so we're okay there. And this all aligns quite nicely, so I won't say that. It doesn't look like a posterior dislocation because you'd expect everything to be moving backwards as well. Hang on, so let's move that across. So that looks like it's not a fracture. Sometimes you can be careful and not miss a rib fracture. So let's have a look and see. Have we had any polls? Anyone come in? Let's see what we think. Should we end the poll? And have a look what people think. So no rib fractures, no pneumothorax. Everything looks okay, except when you zoom in. So let's zoom in a bit, and pan across and zoom in some more. So you've got your humerus sitting there. You've got your lateral acromion sitting there, but now you've got these kind of hyperdensities sitting within those regions over there. So this would be in keeping with, hang on. Good. So yeah, this looks like these are tiny calcific densities sitting within the region of what the foot plate. So it may actually be in keeping with a calcific tendinosis of the supraspinatus. That's going to be the most likely place. So then, sorry, just give me 1 second. Sorry. Have we done that poll yet? Just can we just release that poll? Rabia, did you get my food? Uber, I think it's outside. Okay, so what do we think? What do people think? Okay, let's go to the MRI scan and have a look. So now again, we're looking at the fat saturated images again. And yeah, so someone said reduced subacromial humeral space, supraspinatus calcific tendinopathy. Yeah, so that's exactly what it is. Exactly. So this is calcific tendinosis. That's what this is. And you can see that there is Okay, can you switch it off now? And no, take it downstairs. I'll get it later. Sorry, my daughter's coming. Um, yeah, so you can see this calcific tendinosis sitting over here, and you can see this is the fat saturated images, right? And so the fat is dark, and you got your supraspinatus. I mean, you got your trapezius supraspinatus, and looks like you got your infraspinatus there. So where does this attach to? Where's all these calcifications? So yeah, this does look like something with a supraspinatus tendon. So and then someone said, yeah, so there is a bit of fluid in the subdeltoid bursa, and you can see there's a bit of acromioclavicular junction osteoarthritis. When you get osteoarthritis of the acromioclavicular joints, sometimes that can cause some impingement, kind of grows under and pushes under like this. But that's not what's going on here. We don't have that. What we have is a bit of arthritis, but no impingement, and what looks like these calcific densities sitting within the supraspinatus. Now, the other way to make sure you know where you are and orientate yourself nicely is look at this view. This is kind of your, I guess it's like your Y view, isn't it? And so now you want to just try and make sure that you can find, orientate yourself. So the most anterior aspect of the shoulder is going to be your acromion, your acromion process, which is going to be this thing over here. Then you've got your no your coracoid process. Your subscapularis is over here. You're going to have your biceps tendon, and you've got your supraspinatus over here. So come forwards, come forwards, come forwards, come forwards, and there, it's getting thinner, 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 and then it becomes kind of blobs, blob, blob, blob. So that's going to be calcific tendinosis. That's exactly what that is. So yeah, well done. You guys have picked that up, and I've now shown you on MRI. Now on T1, no, it's not so easy to see on the sort of more T1 weighted images. It looks kind of a bit bulkier on that area. But yeah, that's calcific tendinosis. Is that a tear? So let's have a look. So the way I always try and explain it to my registrars is like, imagine that this person's got like this is a head of a person, right? Right. And you should have some hair on this side, hair on this side, and hair on this side. And if you don't have any hair, then you're kind of a balding person, or sometimes you've got no hair at all, and that means that you've got completely lost all your rotator cuff. Now this one, it seems to me is that there's hair there, there's hair there, there's hair there. Keep coming, still got hair, still got hair, still got hair. Keep coming, still got hair, still got hair, still got hair, and then you kind of got this bicep tendon that's coming just underneath there. So actually, I don't think there is a rotator cuff tear at all. I think that actually you've got a lot of tendinosis, and there's calcific. You've got a lot of like edema within that tendon itself, because tendons should really be black, but you don't. It's kind of edematous, and you've also got this calcific tendinosis sitting here. But actually, when you look for that hair thing I was talking about, it doesn't look like there's any full thickness tear at least. Some people might say, oh, there could be a bit of surface fraying, but actually, to me, that surface there looks pretty smooth. So I don't think there is a tear on this particular patient, unless you're not talking about the supraspinatus. Right. So we've done the shoulder. So this is one of the donated cases we had actually. I'm not going to pretend I know a huge amount about this one, but I thought it was really interesting, and I really do genuinely appreciate it. A few cases were donated literally the last minute after we'd got everything set up. So I'm going to have to just push those ones on to next time. But this one, um, yeah, I don't know if I would have got it straight away, but they've actually said what it is. And the thing that they have, well, okay, I mean, obviously you guys have a look and tell me what you guys think, but we'll kind of work through it systematically. And you kind of look around for fractures. And so basically, generally speaking, it's going to be the fourth and fifth metacarpals that get fractured because of the way that people punch. But I can't see a fracture here at all. And now when you look at the joint spaces, you can see the joint spaces are actually fairly well maintained. I normally try and zoom in a little bit more, just to have a look and make sure they're all okay. So there's no kind of joint space loss. I can't say there's osteoarthritis. And let's have a look. And then yeah, someone said it exactly right. So now when you try and draw around the contours, generally speaking, they should be kind of nice and rounded like this. But can you see this kind of hook coming out that way? On that, particularly on that first, second, and third, like a hook osteophyte. I don't think I can see any more. Obviously, if you guys see more, then let me know. But I can't see any others. It really does look like it's going to be that's one, two, three. The third metacarpal got hook osteophyte, which would be in keeping with hemochromatosis. So quite an interesting case, actually. I don't think I've ever really, seen one in the wild, unless I've made a miss. But yeah, I think it's a really good case, and that's kind of one of the musculoskeletal manifestations of hemochromatosis. And so, yeah, I really, really appreciate that, because now all of us have seen what it's like, and we'll keep an eye out for any sort of hooking. And if it's hooking, then go H for hooking, H for hemochromatosis. Like, try that. Okay, cool. Let's go on to, oh yeah, someone said it as well, unless you're the one that donated the case. Maybe it was you. Anyway, all right, let's have a look at this one. This person has come in, what were they? Were let's say abdominal pain. So CT abdo pelvis. And let's have a good look through this one. So first off, it is a contrast enhanced study. And it looks like, oh, hang on. I'm just gonna break my fast. Can you guys just have a scoot through this one while I have a drink of water and have some dates, and then we'll go through this case. Oh, that feels so good. Tell me what you guys think. Yeah. Sorry, someone said, well, there's a pleural cancer, said asbestosis. There are some calcifications within the pleura. That's true. Let's scoot through the whole thing. It came with abdominal pain, remember? I'm really sorry if you can hear me crunching away here. Hmm. Lots of artifact. Okay. Hematoma. Yeah. Okay. Good. 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 Okay. Fine. Let's work through this, right? So, with every single patient, if I haven't seen the abnormality, I always go through a system. You are right. There are multiple calcified pleural plaques located within both hemithoraces. I wouldn't go down the cancer route just yet because, I mean, you'd normally be looking for sort of mediastinal pleural thickening, but we don't really have that. We've got multiple pleural plaques. You do have a small hiatal hernia. Now let's have a look. Yeah, well done. You can see that the gallbladder is nice and thin, no inflammation. The kidneys, they look pretty good, don't they? It doesn't look like they're inflamed at all. And then the pancreas can also cause pain. That looks okay. And the spleen looks okay as well. Want to have a quick look at the bowel. Lots of artifact, but we can still find the bowel. Follow that. Oh, it's tough, isn't it? Goes that way, does it? Yeah, back again, back again. Oops, sorry. I don't know why the emojis keep coming up. Then we're coming up to the ascending colon. There is some diverticulosis, but everything else is okay. Then come across the front, come across the front, come across the front, come across the front. What is that? They look like calcified things, are they? Yeah, so calcified lymph nodes, which I heard like can come from like calcified from having pasteurized milk, non-pasteurized milk or something. But anyway, I see them fairly often. I kind of just ignore calcified lymph nodes. Someone said cirrhosis. Yeah, it does look a bit irregular, doesn't it? It doesn't look very, very sharp. It looks kind of slightly knobbly. So you could say some cirrhosis. IVC looks okay, aorta looks okay. So we may say, okay, well, it's fine. We don't need to do anything else. Let's have a look at the lung bases. Lung bases, yeah, a few bands of atelectasis and maybe even a small pleural effusion there. And someone has said correctly, there's quite a large pericardial effusion, doesn't it? It looks like quite a big pericardial effusion there. Look at that. Right. Now, yeah, you come down and have a look at the rest of the body, and you may have spotted, and a few people have, so well done. You got the rectus muscle there, and you got your rectus muscle there. And unless they've been like doing ab crunches just like on the one side, there's no reason why you should have like an asymmetry in your abdominis muscles. So this looks very, very expanded. And actually, when you look around here, can you see this hyperdensity? If we zoom in a bit, let's zoom in. Oh, hang on, zoom and pound. You can see there's a little hyperdensity located within there. So when you get expanded, well, subcutaneous tissues, muscles, anything like that, and you've got that sort of very focal hyperdensity sitting within there, you have to be worried that this person is actively bleeding. And they're actively bleeding, and that's the reason why the rectus femoris muscle looks so large. It's because it's got yeah, evidence of it's basically bleeding into that rectus muscle and causing it to expand. So it's not, I mean, I was joking, it's not because they're doing exercises on one side of the body only. And actually, you can see there's a fair bit of subcutaneous edema over here as well. So you wonder whether they were actually like a trauma patient. Had some, focal impact, and then they've ended up having a intramuscular hematoma, which is actively bleeding, which is causing their abdominal pain. Right. So what I'm going to do, I'm going to try something a bit different because I'm going to play a video because I went through a case earlier, so they would give me a little bit of time just to pray, and then you guys can watch, and then I'll come back and go through the rest of the cases. So if I go to this one, video, share, and then this one. Okay, so here we go. I'm going to play this video of me going through another case, and I'm going to keep quiet. Okay, so what we'll do is go through to this last case here, click on open review, and then come here and then make sure you click on these cloud buttons, right? I've already done it. So what we're now going to do is just have a look at the CT scan. So let's start with the CT scan. And straight away we can see that this is a non-contrast study because there's no contrast sitting within the aorta. Portovenous system also looks like there's no contrast sitting within there as well. So this is a non-contrast study. The only thing is that the table is sitting over the back here. So the patient is actually lying on their back. So it's probably not a CTKB. I have worked in somewhere where they um, did CTKBs with them lying on their back, but generally speaking, most places won't do that. Normally they'll be lying on their front and the table will be sitting over here. I think it's got some to do with the ureters being slightly mobile, and also the fact that the urinary bladder, if it's got the stone sitting at the back, even though the patient's sitting at the front, it must mean that the kidney stone is lodged somewhere, like lodged in the vesicular junction. But with this one, this is not a CTKB because they're not lying in that correct position. Right, so it's probably a non-contrast study. You've got to think about the kidneys then, because why would you go with no contrast on this study? And actually, their kidneys look okay. It doesn't look like there's much going on, except there is a small calculus located just over here. So it's possible. So I'll have a look at the ureters. The ureters go all the way down to here, and we don't see any renal calculi. Coming all the way back up here, no evidence of any renal calculi on that side either. Let's have a look at this gallbladder. Gallbladder looks pretty good. It doesn't look like it's inflamed. The liver looks okay. Looks nice and sharp, doesn't it? Look a nice sharp contour. So we're not looking at underlying cirrhosis or anything like that. Pancreas can be another cause for pain. So have a look at that pancreas and just see if that's okay. Yeah, that looks right. It doesn't look like it's inflamed at all. And then we're going to have to do the long hauler look at the bowel. So actually, there's two bilateral inguinal hernias containing some fat. So looking at the bowel, scroll up, scroll up, scroll up. Look, this is where my mouse is. My mouse is here. We're here. And then where are we going? Where are we going? Okay, so I'm going this way. So there is some diverticulosis, but no diverticulitis. Come up to the ascending colon. We were at the splenic flexure. We're going to come right across the front, right across the front, right across the front. So it's transverse colon, connects the hepatic flexure, coming to the ascending colon. And here it starts to look a bit strange, doesn't it? It doesn't look quite right. Lots of sort of fat stranding. So this is fat stranding. This is what fat shouldn't look like. Fat should look like this stuff. Fat should look like this stuff, not this stuff sitting over here. So it's quite inflamed. And we've got to try and figure out like what part of the bowel we're in. So this looks like this is the appendix here. Look, appendix, appendix. Looks inflamed, but so does everything else. The cecal pole, the terminal ileum, all looks very, 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 very inflamed. And it looks like there's no perforation from what we can see, and there's no collection. Let's make sure. Let's go to here. Yeah, no perforation, no collection present. So actually, we're just looking at really inflamed bowel. Now there is this hyperdensity sitting within here, and I have actually seen a situation where someone had swallowed a fishbone and actually ended up getting lodged within the terminal ileum area. So, I mean, it does look kind of sharp. It doesn't really look like a fishbone either, but you can definitely say there's a lot of inflammation located within that right iliac fossa, most likely within the region of the terminal ileum. Now, there are a few lymph nodes. Can you see that? See this one here, that one there, and that one there. Is like if you kind of scroll through, they come and go. They kind of come and go, and most things in the human body sort of continue into one another. But these lymph nodes, they kind of come and go, come and go. So very, very inflamed in the ileocolic chain, and it all kind of extends upwards, more inflamed, sort of enlarged lymph nodes all the way up and within the right mid abdomen as well. So it looks like lots of inflammation, which kind of pushes us towards the idea that it's probably going to be an infectious thing. So, like we said, it doesn't look like there's a collection. There doesn't look like there's much in the way of a perforation. And actually, incidentally, there is a right-sided actually bilateral pleural effusions and a few bands of atelectasis located within lung bases. So we're all done. Everything's good. Well, it's not good. It's not great for the patient, but we have found out the initial and most acute problem. Well, we do have to look at the rest of the study. We've done the lung windows. Now we've got to look at the bone windows and make sure we have a good look around and see if there's anything going on. So coming up to sort of the hamstring area, you can see it looks like there's a bit of ossification of the hamstring origins. Rest of the tendinous insertions look okay, which is good. Pubic symphysis looks okay. Sacroiliac joints. Now that does not look normal. Can you see the sacroiliac joint there, sacroiliac joint there? Kind of almost non-existent. So that doesn't look right. So you've got ankylosis of the sacroiliac joints. And actually coming further up, if we were to zoom in a bit and have a look at the actual facet joints, they are completely connected like these. Actually, some of them are connected. And actually, these look like they're pretty much ankylosed. There is some joint space there, which is which is good. But then a lot of the joint space is kind of gone. And if you go to the NPR and go, let's go sagittal. And now you can really see that this person's got significant ossification of the anterior longitudinal ligament. You've got calcification of the posterior longitudinal ligament all over here. Yeah, you've got significant, and now you can really see the facet joint um, ankylosis as well, which is predominantly within the sacral regions, right? But you can see how significant it all is, all kind of like a sheet calcification. So with these situations, we're very, very careful. You've got to kind of really look and see whether there's any fractures, because I've had a situation where someone came in for something totally unrelated and they actually did have like a 3-column injury. And this one doesn't look like they've got a 3-column injury at all. It all looks like it's quite nice actually. It all looks like it's nicely aligned with one another, and there's no evidence of any fractures. Now, if we go to the coronal views, and now let's have a look again, we can see like how significant like of a bamboo spine they've got. Like it properly looks like a stick of bamboo, and actually you can see significant ossification of these posterior longitudinal ligaments going along the spinous processes as well. And you can see the ankylosis of the facet joints as well, and the sacroiliac joints. Let's see what they look like coming back. Yeah, they're pretty ankylosed, aren't they? They're completely gone. So you kind of got a dual pathology here. One's like a short-term problem. The short-term problem is you've got significant terminal ileitis. And as far as I'm aware, I can't find any association between ankylosing spondylitis and terminal ileitis. I mean, maybe one of you guys can tell me, but I can't see anything to do with that. But there's definitely so the more acute problem and the long-term problem. The reason why I think it's quite important to go through this case is because the long-term problem of ankylosing spondylitis is often underdiagnosed, right? So a lot of these people will just sort of have back pain, have like medication and all that kind of stuff, but never really be investigated for underlying ankylosing spondylitis until it gets quite far. And so that's why I think it's quite important to really keep that in your mind. And also, if you do find ankylosing spondylitis, make sure that regardless of whatever else is going on, there's no 3-column injury, because they're going to be prone to that kind of thing, right? Because of the nature of the disease. Okay, so I'm going to hand the thing back over to myself, if that makes any sense, and I hope that's been useful.
Okay, yeah, I hope that wasn't too weird. So yeah, I hope that was an interesting case. So let's go back to sharing my normal screen. So desktop 2, there we go. And I saw I've never heard that name before. Someone said MB Bechturu. So I was actually Googling that. I didn't know that. Well, that's like another name for ankylosing spondylitis, is it? I didn't know that. Cool. Right, so let's go to case number 7 and have a look and see what's going on here. So let's do the cloud button. And this one, what was this one? Okay, I think it was abdominal pain again. We just go with abdominal pain. Right, so let's go from the top. So this is a contrast enhanced study. I can see the contrast sitting within the aorta and the IVC. The aorta doesn't look that bright, and the porta vein looks slightly brighter. So I guess it's a porta-venous image, right? So let's go from the very, very top, scroll all the way down, all the way down, all the way down. Just do one scroll all the way down, all the way down, all the way down, all the way down, all the way down to the bottom. So yeah, hopefully this is a bit of a more straightforward one compared to the other one. But again, if you're not sure, let's go through systems. Gallbladder is okay. Nice sharp liver. Kidneys, they look okay as well. They don't look like they're particularly dilated and don't look like they're stranded or inflamed in any way. And then you've got your pancreas over here. That looks okay. And your spleen looks okay. Now we've got to do the proper work, go from the rectum, coming up. Oops, sorry. There must be some certain keys I'm pressing. So coming up, and there you go. Quite a lot of inflammation sitting over here. That's normal fat, that's abnormal fat. And actually there's a few locules of air just located within its vicinity as well. Can you see that? There are some air locules that are outside of the bowel. And then you come across. Let's come up to the descending colon, all the way to the splenic flexure, all the way across to the front, like so. Keep watching your eyes on my mouse, keep your eyes on the mouse. Now at the hepatic flexure, now we're at the ascending colon, and now we're at the very, very bottom. And actually everything else looks okay. So yeah, this looks like a diverticulosis. Important negative would be, is it perforated or if there's a collection? So I think we can definitely say there is a perforation, but actually when you zoom in a bit,
some of that doesn't look quite right, does it? So let's see. No, that is definitely, yeah, definitely perforation. I was worried there could be some fecal material because sometimes you get, yeah, fecal material escaping, and I've seen some horrendous ones over the years. But this one doesn't look like as much in the way of fecal material, but definitely inflammation, lots of like prominent lymph nodes within the area, I think, and no evidence of any collection. Now, there was a case, and I don't know if you guys remember it. Actually, will come up in tomorrow's talk, which I'm doing for Everlight if you're interested. But you look for perforations and you just have a look around with to see if there's any other locules of air anywhere else. And actually, there's nothing else anywhere else. So this is a kind of a focal perforation of an acute diverticulitis. Okay, so let's have a look at this next case. You thought there was a pericolic abscess. Let's have a look. So someone said they felt as though there's a pericolic abscess. So what I'll do then is just to be 100% sure. So sometimes, I mean, yeah, you could, and you have to look underneath, I guess, just look around. So you said there could be an abscess. So, I mean, an abscess would be a collection, right? So I can't say I can see like a proper focal collection because that's going to be, look, rectum, rectosigmoid junction, sigmoid colon, coming across, back to where it was perforated. And yeah, it just looks like there's lots of air. So I don't think I would really go for a collection on that scan, personally. Okay, so we are now going on to this case and see what we think. So this was a road traffic, well, you used to say accident, but apparently you're not allowed to say accident. It's a road traffic collision. Okay, so road traffic collision, unfortunate. So let's go from the very, very top. So we're over here, go scrolling down, scrolling down, scrolling down, scrolling down. So at first, it looks like there's nothing hugely abnormal at first. Posterior fossa looks okay, and CSS base look pretty symmetrical. So then the one thing I want to do is whenever you've got any of these sort of injuries, you want to have a look at the front of the front of the head because acceleration, deceleration, your brain keeps moving, but your skull stops. So you get some impact areas located within the frontal areas. Let's have a look. And actually, yeah, can you see there's a little kind of impaction there and a bit of low density around it. So there's definitely some edema. So this looks like there could be contusion bleeds and maybe a little bit of blood further down. Diffuse brain edema. Okay, so yeah, I think this is a young patient. So when you come up to the skull vertex, you can still see quite a nice sulci. So I wouldn't go for like a cerebral hypoxia on this particular one. I'd be very careful about that. And I think often when I do exam teaching, I do a lot of FRCR teaching these days. So yeah, people when they panic and they're not sure, they'll just go for hypoxic brain injury. But actually, you can see sulcus spaces quite nicely. I think it's just a young patient that's unfortunately had this incident. So then the other places that you can get these impaction injuries are going to be the temporal lobes. You've got to be very, very careful because that's another area where you can actually have like the brain hitting forwards like this. And you do wonder or worry there could be some bleeding there, but I haven't seen anything obvious there at all. Now, I often find that the brain windows is not the best window to do. So you kind of got to window it slightly a bit just to make sure there's no subtle bleeds anywhere else. And actually, when you come to the top and just window a little bit more, there's a bleed there. Can you see that there and there? Coming down. And now you can actually see, yeah, it feels like it's doing that. Little tiny bleed there. Going along like so, going along like so. So there's also a subdural hematoma as well, right? So there's definitely subdural hematoma and a few contusions as well. We just want to make sure there's no other bleeds anywhere else. So sometimes you can be caught out. I mean, you could potentially think there's a bleed here as well. Can you see that hyperdensity there? Yeah, I think there could be some more subdural hematoma sitting over the posterior aspect. Anywhere else? Anywhere else? I still worry about these temporal lobes. So whenever I look at the temporal lobes, I do normally do the sagittal views and just make sure there's no kind of hemorrhage along the temporal lobes. So actually, I don't think I can. Actually, can you see there? Can you see that stuff? Let's window a bit more. Just feel like there's some hemorrhage there, just in front there. Let's go to the other side. Not so much on this side. But definitely, I felt like there's a bit of a hemorrhage on this side. Someone said diffuse axonal injury. So diffuse axonal injury is a possibility. But generally speaking, with a lot of diffuse axonal injuries, you don't really see, you can actually get normal MRI, CT heads. and they look normal, but the GCS doesn't get better. You do another scan, looks normal, and then you take them to the MRI scanner, and then do you know what that one that's famous, that kind of thing. They say the scanner's broken, but you can only have one sequence. What sequence is it? Do you know what sequence you'd get with a diffuse axonal injury? So it'd be, yeah, exactly. Because say SWI or but gradient echo sequences. No, gradient echo sequences. Those are the ones. Because your gradient echo sequences, basically what happens when you get tiny little bleeds, they're like little tiny magnets. And so you need a sequence that's going to be disrupted by like the most minor of magnetic forces, right? And so when you got the gradient echo sequence, the tiny bleeds will look like big fat circles. And they just look like exaggerated black circles all over the place, like signal voids. And so that's what you end up getting. And I actually do have a case. Maybe I'll bring it up next time. But there was normal CT head, MRI scan, gradient echo, boom, 100% diffuse axonal injury. Okay, so the last thing I'll do is also check the bones, by the way. So be very, very careful with the bones. Honestly, these days I've got to be even more careful, especially um, transtentorial herniation. Let's have a look. So you'd be expecting a lot of mass effect for transtentorial herniation. Transtentorial would be somewhere down here. And actually, this all looks very sort of symmetrical. And when you go to the coronal views, so what, that's your tentorium, isn't it? That's your tent, and you'd expecting some herniation over there. So you don't really have much in the way of any brain parenchyma pushing over and under. So I don't think there's any transtentorium herniation. You've got your falx over here and any subfalcine herniation going this way, not that way, and nothing coming this way. Everything looks like it's nicely aligned. So I don't think there is any transtentorial herniation. Now, what I would, if I haven't said this already, I'd highly recommend that whenever you do these kind of looking for fractures, do use these MIPs. And so I'd do quite a big MIP, go to like 30 or 40, and then you want to window a little bit. Hang on, let's get the windowing. Let's window a little bit more. And now what you can do is you can look for a fracture. And so let's window a little bit more. Yeah, I think so too. Yeah, someone's basically said these are really nice MIPS considering it's a browser. Yeah, I'm consistently impressed with these guys. And if you don't know, when I do my teaching, I use Collector Minds because it's just easier and they've got everything that I need to teach the registrars and stuff. Okay, so let's have a look. So now it feels like I'm holding like the skull in front of my hands, doesn't it? Because I've MIPed it and I've kind of windowed it a bit to try and look for any fractures. And I really find that this is a great way to look for fractures. So let's go to that. That was a front. So there's no fracture there. Go across to the back. Oh, hang on. You see that? There's a line there. So if you're not sure, then what you can do, yeah, look, come from the underneath. Can you see that? It's definitely looks like it's a fracture going like this all the way around the back. All the way around the back. Okay. And if you really want to see it properly, then you can start sort of angulating things a bit more. So how do you do that again? He says, okay, so you click on this little arrow like this, and you can really just completely spin it around. So it's going to be something like that to get the best angle on this. And you can see that line going all the way like that. And it's amazing, like at first you don't really see it. So let's see if we can find it now on the bone windows. So that would be around the back somewhere, wouldn't it? There it is, right there. That fracture is going right down there, right down there, right down there, right down there, and then through into what looks like the foramen magnum. So quite a lot going on there in the end. So at first it didn't look like there was much going on, but it looks like there's a fracture in the posterior skull, basically. If they had the impact there, then maybe these are sort of acceleration, deceleration injuries or contra-coup injuries. I mean, that might be what's going on as to why they've got the fracture at the back, but then got so many abnormalities in the front. But yeah, this is a good case because you can imagine, especially when you first start, you could scoot through, or if you're particularly busy, you could scoot through, think it's okay. But what we have here are contusion bleeds, subdural hematomas. We've got contusion bleeds in the frontal lobes. I think contusion bleed in the left temporal lobe as well, and a skull fracture. So yeah, definitely 100%. I would use these MIPS, and I don't know why it's not taught, but I would definitely 100% use those, and I genuinely use them every single time I look at any trauma scans. Right. I think that is the. Oh no, we had one more, but actually that was the recorded one. But on the recorded one, I realized that I didn't talk about the X-ray. And the only thing about the X-ray was that, yeah, you can see it looks like a dagger, doesn't it? That proper dagger. So that calcification of that ligament going right down the middle. is giving you the giving that appearance. Someone says mipping is very good for lung nodules. Yes, 100%. And vessels, yes. So that's something I've recently started doing, having got some advice from a friend of mine. And I haven't picked up anything on it yet, but yes, I'm starting to use those as well. So I guess with can I do it with this one? Maybe. So if I download this, sorry, I might run over time just doing this, just so that people know what I'm talking about. Um, so this is something I didn't always do, but something I started doing. So just wait for it to download. Hopefully it won't take too much longer. Come on, mate. Come on. Almost there. Can we do it? Can we do it anyway? Not quite. Okay, so here we go. So what we're talking about, someone said that you can MIP to look at the vessels. So these are the vessels. Can you see the mesenteric vessels, right? So then what you can do is do this. MIP, 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 MIP. And now you can see the vessels. And why is that useful? It's because, like, if you're worried about a blood clot, right? So remember, I've said this before, like everything in the human body normally leads to something else. If you've got a vessel and it's doing this kind of branching round and it suddenly stops, then you know there's a thrombus. So it's a really, really good way to look at these vessels and just really interrogate and see whether there's any sort of vascular obstruction within the mesentery like this. Just have a look, have a look, have a look, and have a good look. But anyway, right, I think that's the end of my talk. Thank you so much for coming. For those that are doing Ramadan Mubarak, I hope it's going well. It's been pretty tough this year. And I've actually ordered some food, which just came, my daughter came in. She came in with like this kebab, which I'm saving for after the talk. So I'm really looking forward to getting back to that. So yeah, thank you so much. I really appreciate it. I'm going to hand over back to Danish, and then I'm sure he's going to want to break his fast and eat and all the rest of it as well, isn't it? All right. Bye, everyone.
Thank you, Imran, for another great webinar. And yeah, thank you everyone for being so patient with us whilst we broke our fast as well. Really appreciate that. I'm just going to put the link to the survey in the chat now, so do fill that in and we can send out your CPD certificates for you there. I'll leave that link up for a while just so you can all get access.